Dear colleagues, today I present to you the case of a cardiac anomaly, namely pulmonary stenosis, which has a low incidence in the prenatal period. In fact, it accounts for about 3% of congenital heart diseases and manifests as an obstruction of the flow from the right ventricle to the pulmonary circulation, most often due to abnormalities of the pulmonary valve itself. In fact, supravalvular and subvalvular forms are rare, caused by narrowing above the valve or hypoplasia of the pulmonary branches. In the case of supravalvular stenosis, it is due to hypertrophy of the ventricular walls, while in the case of subvalvular stenosis. Among the valvular forms, which are the most common, the one with the highest incidence, 75% of cases, is due to fusion of the valve leaflets, often also associated with a post-stenotic dilation of varying degree of the pulmonary artery. Only in about 5% of cases is there valvular hypoplasia with an annulus that appears. The annulus is very narrow and the cusps are absent or rudimentary, which therefore causes both stenosis and regurgitation. The degree of obstruction is variable and can worsen during pregnancy. It ranges from milder forms with a velocity greater than 100 centimeters per second to even critical or very severe forms above 200 centimeters per second. There are even cases of complete pulmonary valve atresia. Therefore, the progressive nature of the heart disease itself makes early diagnosis difficult. In fact, in most cases, the diagnosis is made late during the third trimester. Cases diagnosed early in the second trimester are, in themselves, a prognostic factor for a less favorable outcome and indicate a stenotic form that is already more severe or even critical. On ultrasound, the heart defect appears in the four-chamber view as a discrepancy between the size of the two ventricles, in fact. The lumen of the right ventricle appears reduced. The tricuspid valve is usually normal, but it can sometimes show regurgitation, which becomes significant only in the more severe forms. Right ventricular hypertrophy is usually not evident, except in cases of severe or critical stenosis. In the right-sided flow scan, the leaflets of the pulmonary valve appear whiter, hyperechoic, thickened, and with reduced valvular excursion. They are always visible within the vessel lumen throughout the entire cardiac cycle, even during the ventricular systole phase, when the valve leaflets should be open and therefore not visible. Furthermore, there is this ectasia or post-stenotic dilation present. In the scan between the bases, 3 tracheal bases, the application and use of color Doppler and power Doppler are essential, as they allow us to highlight this turbulent flow through the pulmonary valve, and by sampling with pulse Doppler. The velocity exceeds 100 centimeters per second or 200 in the case of the more severe forms. At the level of the ductus arteriosus, the flow is usually antegrade, but in cases where it is reversed and therefore inverted, this is usually indicative of a poorer prognosis and thus actually unfavorable, and of a possible progression to severe and critical forms. Pulmonary stenosis can also be associated with other congenital heart diseases, including tricuspid regurgitation with Ebstein's anomaly, tetralogy of Fallot, in which the hypoplastic valve and the valvular annulus appear narrowed, and double outlet right ventricle with transposition of the great arteries. Furthermore, it can be found in the context of syndromic conditions, including rhesopathies, particularly Noonan syndrome, in which a dysplastic pulmonary valve is present, Alagille syndrome, and Williams-Buren syndrome, in which the stenosis affects the supravalvular tract more distal to the valve. In this case, the patient undergoes a second trimester screening ultrasound. During the cardiac anatomy study, particularly during the evaluation of right-sided flow, a normal bifurcation of the pulmonary artery into its right and left branches is clearly observed, and a slight dilation, specifically an ectasia, as we mentioned earlier, post-stenotic of the pulmonary vessel. In fact, at the valvular level, the valve appears hyperechogenic, whiter, and always visible even during the ventricular systole phase, when it should not be. When sampling the vessel at the valvular level, it shows a velocity just above 100 centimeters per second. Then, by applying the power Doppler, the vessel's lacing is clearly highlighted due to the presence of slight turbulence and increased velocity. Moving forward to examine the four-chamber scan, we can clearly visualize both ventricular cavities, and in particular, the right ventricle shows a notably smaller luminal space compared to the left. The pulmonary veins are normal. Then, by applying the power Doppler, it is still possible to highlight this discrepancy in the filling of the two ventricles, right and left, with reduced filling of the right ventricle. In particular, it is evident. Also, the flow through the tricuspid valve, although reduced, as well as the triventricular valvular excursion, is less than that of the left side, though still present. This allows us to rule out cases of tricuspid atresia. Moving on to the transverse four-chamber scan, it is possible to observe this normal excursion of the atrioventricular valves, which is obviously much more pronounced and mobile on the left side than on the right. The long axis of the left side is normal. We observe the continuity of the interventricular septum, thus the absence of defects, which also rules out cases associated with tetralogy of Fallot, as well as septal defects. The II and II septa are clearly visible in this scan. Here, the tricuspid valve is highlighted, and in particular, the insertion of the valve is brought to our attention. The tricuspid valve normally has a more apical insertion compared to the mitral valve, but in this case, the septal and posterior leaflets in particular, as we will see now, appear to be displaced even further toward the cardiac apex in the apical view. The repeated observation of the valve's appearance indeed raises suspicion of an association with Ebstein's anomaly, a condition often linked to pulmonary stenosis that causes varying degrees of tricuspid valve dysplasia and displacement, resulting in regurgitation due to the valve's poor competence. When sampling the mitral valve, it appears to be perfectly competent. In contrast, the tricuspid valve shows an almost holosystolic regurgitation, with a velocity exceeding 200 centimeters per second, as seen in severe valve insufficiency. A condition of such magnitude is usually not typical of mild or moderate pulmonary stenosis, and is therefore probably due to the concomitant presence of Ebstein's anomaly affecting the valve. On scanning the tracheal base, the pulmonary artery and the aorta are located to the left of the trachea, but a reversal is observed at the level of the ductus arteriosus, and this too is an aspect that represents an indicator of greater severity of pulmonary stenosis and a less favorable outcome. By also observing in the sagittal view the aortic arch, the ductal arch, and the pulmonary artery in particular, at this point we always see a ductal arch that shows this reversed aspect, therefore with an inverted flow, as well as the presence of the pulmonary artery, and the fact that it is not reduced in caliber or ruptured. Its absence allows us to rule out differential adenotic pores in cases of pulmonary atresia. The remaining anatomy appears normal. Situs solitus, the stomach is visualized, the bladder is normally full, and there are 3 umbilical vessels. The amniotic fluid, in turn, appears normal with no signs of cardiac decompensation. In all cases of complex heart disease, especially considering the association with genetic syndromes, but also in cases of isolated heart defects, it is essential to request genetic counseling with amniocentesis to investigate the karyotype, RSGH, and possibly the exome. It is essential to perform echocardiographic follow-up with serial echocardiograms to assess the progression of the condition, in particular the increase in velocity across the pulmonary valve, the worsening of tricuspid regurgitation, and cases of right ventricular overload.